Yeah. Hi, everyone. My name is Waleed Ahmed. I'm one of the acute medicine registrar in the NHS hospitals in the United Kingdom. First of all, I would like to say thank you for the organizers for giving me this opportunity to present my quality improvement project. The topic of our QIP was to assess the discharge letter and to compare them against the NICE guidelines, which suggest that all the patients that are treated for ACS should, or when they are discharged, relevant information should be sent over to the primary care, which are the general practice here in UK, with all the information about the secondary prevention medications. So our clinical audit we performed, and then the quality improvement project we did after the interventions. I would like to share some background and the results of our QIP today. Just to give a bit of a background, NICE, which is the National Institute for Health and Care Excellence, give guidelines on different topics and management for different pathologies, which are followed across the United Kingdom. So they published the guidelines back in 2020 to say that the secondary prevention medications should be started on patients with ACS, and they also guided that these information should be provided to the primary carers by the parent team of the patients, and this information should be included in the discharge letters. Other researches and data has shown us that these medications have a positive impact on the outcome for these patients, that reduces rehospitalization, reinfarction, and also reduces the death in these patients who get appropriate secondary prevention medications. Of course, if these secondary preventions are poorly communicated to the primary care, then it has the effect on the patient's health and the outcome for these patients, and have poorer patient care. So the first medication, the foremost for patients in acute coronary syndrome is aspirin, and NICE suggests that patients should be given lifelong aspirin unless they are anticoagulated or there is another form of contraindication or they are intolerant to aspirin. And NICE also suggests that these patients should be on another second antiplatelet therapy. They should be on dual antiplatelet therapy, either most commonly used ticagrelor or clopidogrel, in combination with a low dose aspirin, depending on if they had a medical intervention or a surgical intervention. And the duration for the second antiplatelet therapy should be recommended by the initial prescriber, in our case, our cardiology department. They said that the second antiplatelet medication is usually given for 12 months at least. ACE inhibitors, another important secondary prevention medication. NICE suggests that they should be up-titrated every 12 to 24 hours while the patient is still in hospital, and ideally we should up-titrate it to a maximum tolerated dose or to a maximum allowed dose, whichever is the lowest. If it can't be done while the patient is in hospital, it should be done in the community within the 4 to 6 weeks of hospital discharge from the hospital, and the target dose should be told by the prescriber. People who cannot tolerate ACE inhibitors, of course, they should be put on angiotensin II receptor blockers as an alternate. NICE suggests that ACE inhibitors should be continued indefinitely after MI.
Rob, we can't able to hear you.
Hi, sorry.
Yeah, now I can hear you. Again, your voice not.
Sorry about that. Can you hear me now?
Yeah, I can hear you then.
Okay. Did you hear my previous slides?
Yeah, previous slides just stop that time. I just stopped.
Okay, all right, thank you. Yeah, so NICE also suggests about the beta blockers. They should be up titrated to the maximum tolerated dose or to the maximum dose. They should be done either while the patients are in hospital or in the community, and the plan should come from the prescriber. Uh, Beta blocker should be given at least for 12 months in patient who doesn't have left ventricular systolic dysfunction after MI, but patient who have left ventricular systolic dysfunction should have an indefinite period of beta blockers. Uh, so the aim of our quality improvement project was to ensure that the patients are receiving the recommended secondary prevention medications, and to assess that how well we were communicating this information with the primary care providers, which are the general practice in the community, and to see if we are doing as if our department is doing as per the NICE guidelines. Uh, so after we did our clinical audit, the interventions we did to try and improve the results, I will share my results from the first cycle in the next few slides. But the interventions we did was we educated the junior staff and the junior doctors and the advanced nurse practitioners in our department by presenting these figures at our local departmental meetings and teaching sessions. We also made posters and displayed them in our ACU ward and also in the general cardiology ward. We had teaching sessions and we educated the nurses to check all the discharge letters before the patient is sent home or before the letters are finalized, to make sure that all these information mentioned in the discharge summaries. We are also in progress to make so Jack is our software it's a prescribing software that we use in our department. We are in progress to make a protocol that will drag this information from the clinical notes into the discharge summary that we electronically send to the general practice. We had this is the flowchart diagram for the patients or for the pool of patients that we included in our study. At first, we had to exclude patients that were, of course, not discharged from the cardiology service, because our hospital is not a primary care PCI center, so we have to send patients with NSTEMI or with STEMI to the PCI center. So some of the patients were excluded because they would not discharge from our department. Some of the patients were excluded because they died while they were in hospital. So at the end, finally, we had 81 patients on which we did this study as a cohort. So we gathered these discharge summary, and then we assessed these discharge letters to see if they had aspirin prescribed and if the duration is clearly mentioned. We looked at for the second antiplatelet therapy as well. We checked if the ACE inhibitors has been prescribed correctly, and if there is the plan for uptitration is documented. So for the beta blockers, we also looked for if these medications were not prescribed and if there is any valid reason for not doing so, so that the primary care providers are aware of the reason for not doing it. Our target was the compliance for 100% for all these measures. These are some of the results in a table after the intervention, after we did the quality improvement, and these are the results after the intervention. In the brackets is from the audit we did. So you can see we had marked improvement in the percentage of letters that contained the information about aspirin. 32% of the letters had aspirin prescribed as compared to 12.5 before the intervention. There was a drop in the prescribed aspirin with no mention of the duration, so that's good. There was a drop from 30% to 8.1% in the patients that were prescribed aspirin but not mentioned on the discharge letter, and there were drop from 25% to 10.8% in the letters where no appropriate reasons were given. So if we didn't prescribe aspirin for some reason, we did started to mention the reason why we were not giving these patients that medication. You can see that there is improvement in the second antiplatelet therapy as well. We had mentioned in 32% letters about the second antiplatelet medication compared to 22% before the intervention, and likewise you can see in the other medication going on as well. I will show the same figures in a bar chart for you all to have a better understanding that the interventions we did do had some had improvement in the quality of our discharge letters. So I'll just show you these bar charts just for an idea. So we had some limitations in our study that I would like to highlight as well. Of course, we had a very small cohort of the patients. We only had looked into 81 discharge letter. It's only a snapshot of the services from our cardiology department. But it does portray that we did had some improvement. All the patients, as I mentioned earlier, they were not discharged from a service. Some had to be transferred over for the primary PCI, and this study was only done in our cardiology ward. Of course, there were patients all across the hospital with NSTEMI that we didn't look into their discharge letters. A lot of other patients were omitted from this list as well. Another limitation is we did not reviewed statin prescription of statins, which is also an important part of secondary prevention in acute coronary syndromes. This is a poster that we presented in another presentation. I just thought that it would be better if I can show this here as well. But I would like to focus on the conclusion that we did, although we did improve the quality of the discharge letters, and more letters had more relevant information, and where we were not prescribing patients for any given reasons those medication, like people who were in AKI, acute kidney injury, so we didn't give them Ramipril. So we did mention the plans for the GP to start it in the community when the renal function is better, or patients who were in heart block or in bradycardia. Of course, we didn't give them beta blockers, and we did started to mention those reasons onto the discharge summaries. We are aware that the compliance is still far behind, and the target is 100%, and we need further work, further intervention to try and improve our quality. These are the things that we did try to educate the junior doctors and the pharmacists and the nurses and the advanced nurse practitioners in our department to start with, that all the patients that are discharged from our services, the letters should contain either we are discharging them on aspirin or not. If we are not, the reason should be included in the letters, the duration of aspirin should be included. Same goes for the second antiplatelet medication. That we do want to mention it clearly that it should be given for 12 months, because we had seen there has been instances where patients were given second antiplatelet medication longer than 12 months, and they came back with other different side effects or complications like GI bleed and things like this. So we have to be really careful about the dimension of this duration for these medications. We want to make sure that we have prescribed ACE inhibitors, and the GP, the primary care, they are aware that they have to up titrate these medication up to a maximum tolerated dose or to the maximum dose as a secondary prevention. We also want to tell them if we have not prescribed it, then why we did not prescribe it. Same goes with the beta blockers, that we should be prescribing it, as it's a very important part of secondary prevention in patient with ACS. The duration, either they have left ventricular dysfunction or not. Usually that's looked into in the cardiology clinic, because we don't always do an inpatient echogram for the patients with ACS. Some of the times we do not put these information in the letter only on the basis that we do not have the echo results available, but we do try to give this information in the clinic letters to the GP. So these are some things that we educated our staff to look for in the discharge letter, and to make sure these information are made part of the discharge summaries. So the plan for the future, how we would try and achieve 100% is by doing further meetings and doing further education sessions, teaching sessions, not only in our department, but throughout the hospital. We, as I said previously, we are in the process of linking our electronic discharge software and the medication prescribing software, so that on discharge, this information can be electronically and automatically be pulled into the letters, into the discharge summary, so that we can reduce the manual work as well for the junior staff. And of course, we are aiming to do a whole hospital-wide audit to look and to improve. There's a plan to re-audit after we have made change to our electronic discharge software and the prescribing software. And we are also aiming to include to include statin into our audit when we do look into these data again. These are some of the references for the NICE guidelines and for the information we gathered about how this intervention can help in the outcome of these patients with acute coronary syndrome. Thank you very much.
Thank you so much for your wonderful presentation.
Oh, thank you.
The floor is open for the questions.